we're back. We're going to be talking about traumatic brain injury. Sometimes you'll see that as TBI. Over 2 million traumatic brain injuries occur every year, and about 500,000 of those are bad enough or severe enough that they have to be hospitalized. About 50% of all the traumatic deaths are associated with head injuries, things that, from these wrecks and what have you, falls. More than 60% of all the vehicular trauma deaths are a result of head injuries. Happens more often in males than in females, and alcohol and drugs are often factors along with high-risk behaviors, speeding and that kind of thing, and because of the contact sports. We see a lot of them in the spring and summer, water, boating accidents, that kind of thing. So I don't have to tell it to y'all. Y'all are listening to the news just like I am. Okay, so there's a variety of mechanisms that cause injury: penetrating, blunt trauma, primary and secondary injuries also. And the degree of injury, of course, depends on the velocity and the mass and the shape and direction of impact. So high velocity injuries certainly cause the greatest damage to brain tissue, and those would be like cars, head-on collisions or running into a concrete wall, that kind of thing. So, there is acceleration puts force, puts head in motion, and then deceleration causes whatever's moving to stop suddenly and hit some stationary object or whatever. And then there's also rotational forces that cause damage within blood vessels and tissues and all. Of course, the goals are going to be that we reduce mortality and morbidity from primary and secondary injury. Now, primary injury is one that occurs at the moment of impact. It can be mild, severe, or whatever. It can be open or closed trauma, but we want to try to preserve as much function and all as we can. Now, the secondary injury is what is caused by that impact or the damage that's done there, that biochemical or cellular response to the initial trauma. And we'll see that secondary injury can really kind of grow. So this is real basic, open and closed. You're familiar with these terms from other fractures. It's not any different. The only problem is that now we're talking about some really prime real estate up in your head. And you remember that the head, the skull, is like a protector of your brain, and there's just nowhere for edema to go. There's just so much room up there. So real estate is at a premium price right there. So we have linear. Those are simple, clean breaks. That's probably the majority of skull fractures are that. Depressed, bones pressed inward into the brain tissue, at least the thickness of the skull. Open, that's where the scalp's lacerated, and there's an opening, direct opening into the brain tissue. Comminuted, brain fragments are pushed down into the, bone fragments are pushed down into the brain tissue, just like comminuted is on your leg. Basilar skull, that's at the base of the skull, and it extends upward and inward. And often when we have a basilar skull fracture, we'll see leaking of cerebral spinal fluid from the nose or the ears, otorrhea and rhinorrhea. So they have a real strong potential for hemorrhage also when they have these basilar skull fractures, because of the internal carotid is so near that area, and because of damage to cranial nerves and the likelihood of infection. Concussion is where there's a brief loss of consciousness. We usually have a headache and be irritable, have some deficits in the memory from the accident or what have you, or time around that at the accident. They'll fatigue, and sleep problems. Now, DAI, which is diffuse agonal injury, this is from high-speed automobile accidents. There's like a shearing injury to the axons and the white matter, and they have little small areas of hemorrhage. And they can have immediate coma, and the survivors of this, because it's major traumas, will need long-term care. Contusions, that's a bruising of the brain tissue, and an interesting thing about contusions is that it causes the damage or the injury where they're hit, and then the impact also causes an injury on the other side of the brain. So if someone whacks me, or I'm in a car wreck and I hit my head on the windshield, my frontal, that gets injured. But then that stopping real fast causes my brain to slam against the back of my skull and gives me an injury in the occipital area. And what they call that, and you'll see it written, it'll be coup contra coup. So it's the coup that I got hit in the front, and the contra coup is the hit in the back. So we'll have two areas that will swell. And those are the most common places, the frontal and also temporal is a common place. Laceration, that's actual tearing of cortical surface tissues, secondary hemorrhage, and also can have cerebral edema and inflammation, certainly. And that any kind of swelling in the brain is a matter for concern. So some of the pathophysiology. So the secondary injury can make the primary injury worser. You know what worser is? That's bad. So ischemia is the primary culprit in secondary brain injuries. So it can cause you to lose tissue, brain tissue, that originally wasn't damaged, but because of ischemia, it's kind of rough. And you know what they say about the slogan in real estate? About value. It's location, location, location. Well, that's what we're talking. Prime real estate of your head, protecting your brain or your patient's brain. So later we're going to talk a little about increased intracranial pressure, but I'm mentioning it now because we only have so much space in the skull. So any swelling is significant. There's only room up in your skull for three things: your brain material or brain parenchyma. Anytime you hear parenchyma, that means tissue. If you're talking about lung parenchyma, you're talking about lung tissue. If you're talking about colon parenchyma, you're talking about colon tissue. But we're talking about brain parenchyma. 80% of what's in your head is your brains. I know some of us were thinking, I don't think I have that much, but we do. And then 10% occupancy up here in your noggin is cerebral spinal fluid. And then the other 10% is blood. Any change, any variation in that percentage can be very detrimental to the patient. So if we get a bleed, an arterial bleed up here in your head, all of a sudden we've got a space filling up with blood. It puts the screws to your spinal fluid and your brain tissue, causes it to have injury. So that's what we're talking about. Okay, so let's see. Most common causes of intracranial pressure due to edema on your head, hemorrhage up there, hematoma formation, impaired cerebral autoregulation. That's from all these other problems, and hydrocephalus. So, a hematoma is not too bad if it's in your belly. Got a lot of room to grow, nothing holding it in. But in your head, that's a bad thing. Okay? military injury still, talking about that. We just can't leave it alone. You'll remember from your respiratory lectures that hypercapnia is very powerful vasodilator. So that can cause that second injury if we're not blowing off CO2. We're going to be getting our blood and all, and our head's going to be growing up more. So that's not a good thing. It results in vasodilatation and an increase in the blood flow, and then again increased in the intracranial pressure. So it's like a vicious cycle. Significant hypotension can cause us not to have enough perfusion to our brain as well, and that's another reason we'll get acidotic, we'll get edema up in our head. So got to figure out what's going on and try to correct those things. Okay. If we've got a space-occupying lesion up in the head, and if it's taking up space, and it's going to be causing increase in intracranial pressure. What happens is it'll cause injury because of that displacement of the intracranial contents. I mean, that just makes sense, doesn't it? And we're going to talk about epidural and subdural. Okay. Briefly. The epidural, now, whenever we say something, an artery is bleeding, that makes us stand at attention, doesn't it? Because we know arterial bleed is quick. It can bleed out pretty bad. Have some very grave consequences. So it's into the space between the inner skull and the outermost of the dura, the layer of the dura. Very often we'll get this with skull fractures or with the middle meningeal artery laceration, which can come from those rotation, those DAI injuries and all, where we get the shearing inside, so those high-speed kind of things. So it can be really bad. We don't have them that often, but they have a real, they pack a real wallop with them, I should say. Okay. Very often can happen even from low-impact falls or even high-impact MVAs. And here's what this is: a neurosurgical emergency, an epidural hematoma or an arterial bleed. And we'll have a brief loss of consciousness, like immediately after the incident. And then they'll have, they may be talking to you, and they'll have this brief episode, and then they might come back, have a lucid few moments, and then they'll have a rapid deterioration, and those are signs that they have an epidural bleed, that they've come to, and they've talked to you, and then they've started to be depleted. And that's a bad sign that their intracranial pressure is elevated. So that's a big, big thing. They may get a dilated or fixed pupil on the same side as the impact, and that's a hallmark sign also of epidural hematoma, epidural bleed. So same side, you got whacked on got a big hole in your head from whatever on the right side, and your right pupil is fixed and or blown. So that's, these are what we'll see is loss of consciousness and very tragedy. So we need to let everybody know this, and they're going to be doing surgery on these patients. That's what they'll go in and do a craniotomy and stop the bleeding and relieve that pressure if they can. Okay. So the diagnosis is based on symptoms that the patient presents with, and what we observe, and a CT scan. Okay, and so the surgical thing is to remove that clot. a subdural hematoma. This is a venous bleed. So, however, this one has the highest mortality rate. And very often it's related to a rupture of the bridging veins between the brain and the dura. And sometimes the symptoms go unattended, and we'll talk about why in just a minute. But you can read about these a little bit. There's 3 kinds. What's happening here? Okay. There's acute, subacute, and chronic. And these, all of the subdurals have the highest mortality rate. And and that's because the symptoms can be a little vague. With that epidural, we go, hey, Mr. Smith had a knock on his noggin, and he was talking to me, and then he got drowsy and, started going downhill. So we were right on top of that, and we knew. But with these others, with the subdural, not always that way. You fall, and you get up, and you move on, and you think, well, nothing's wrong with me. I'm not going to the doctor. So we'll talk about these as to why they're sort of unknown to people sometimes. I got ahead of myself. Hold on. There's 3 types. Let me just tell you about them. The acute, of course, that happens. They get a severe blow to the head, whatever. And they usually will present within 48 hours. They know something's going on. Clinical presentation will determine how severe it is, but and how much underlying brain tissue is involved, and how fast the blood's accumulating to put pressure on the brain tissue. So we're observing them, and we'll probably see deterioration of their level of consciousness or some signs that something's going on. The pupils be unequal, that kind of thing. Their motor movements will be impaired. And depending on the size, sometimes if it's a little small one, they'll just let it resolve itself, and if they're not having much problems. But if they're having much problems, they're going to go on in and do something. They're either burr holes to relieve some of the pressure or craniotomy. So that is the acute one within 48 hours of the injury. And then the subacute, this is with, it develops symptomatic. They don't develop symptoms until like 2 days to 2 weeks after the trauma. So you can see how, people don't even think anything's wrong with them. And these happen a lot, or more frequent in older patients. And then, they have other comorbidities going on, so things get masked or what have you. So, with the subacute, within after 2 days up to 2 weeks after the trauma, and the hematoma grows at a slower rate, and so then we start seeing some deterioration. And they may do surgery on that too. Sometimes they'll wait. If it doesn't, they'll watch and see if it seems like it stopped, then they may just let it reabsorb itself. If they have to, they will go in and do surgery. Now, the chronic one, what happens with it, it can happen, appears days to months. Usually we like to say after those 2 weeks to several months after the injury. And often the patients are elderly or late middle age, what have you, and they start having problems with coordination and balance and things like that. And then you'll see some that are also on anticoagulants, and so you can see where that would make a little bit of a problem with bleed in your head. You start having a little slow bleed, and you got some anticoagulants going on, so it can be a very stinky kind of thing. It depends on which areas of the brain are involved, certainly, as to what kind of function the patient may lose or have some disabilities in. So the outcomes are very different on different people. So, maybe they'll return to normal, maybe they won't. The recovery is slow, but very often we may have already had some damage to this tissue that is not often repairable. And so that's in itself all those reasons why the subdural is kind of a sneaky thing, and they have a high mortality rate. Now the subarachnoid or intracranial hematoma, they call them also, it's an arterial bleed also, but it's usually in a different area, and the most common causes are the cerebral aneurysm or an arteriovenous malformation. So those are just kind of the things that we will see. Now looking at the two differences in these main types of situations, you see the cerebral aneurysm and the AV malformation. Some other causes are aneurysm and other vessels, also connective tissue diseases. People are at higher risk if they have connective tissue diseases. Patients with hypertension, patients, interestingly, with polycystic kidney disease. Patients that smoke are at higher risk for having subarachnoids. And also patients on blood thinners, and of course patients that have any traumatic brain injury. So that's some of them. The aneurysm is where they have like a saccular or a berry-like clusters of little aneurysms pooching out kind of things. And most often this occurs at a bifurcation of blood vessels. So where there's a surge of them, that's where it will occur. Also, sometimes we'll see that cerebral atrophy has happened, which could be because of the chronic shunting of blood has caused the brain to kind of shrink up a little bit because it's not had enough blood supply. Those are just some of the things. Now, one of the biggest complications is that these can rebleed, the cerebral aneurysms. So, just one of the bad things. Now, what we often have the patient say is, "This is the worst headache I've ever had in my life," and they'll have a change in their level of consciousness. Now, they may, as a history, they may have had some warning leaks that have gone undetected. They may have had a little episode of syncope, had a headache, and then had a little dizzy spell, or a kind of a fleeting neurological defects, like maybe had some tingling or numbness, and then it came back. So they may have had some little leaks that were warnings, but they might not have heeded them. But usually this headache is like an abrupt onset, and that's when they say it's the worst headache they've had. They might have a brief loss of consciousness, nausea and vomiting. They might get a stiff neck, and they can quickly deteriorate into a coma and death. Let's see. And their diagnosis is going to be made based on their clinical presentation and also CT scan without contrast initially, and then they may do a lumbar puncture. If the CT without contrast is like normal, they'll do a lumbar puncture to see if there's blood in that. They may also do cerebral angiography to denote exactly where the subarachnoid hemorrhage is, so that they'll know where to go in, to do their surgery. So the treatment is that they can do craniotomy. They may do an endovascular coiling. That's where they go in and put this little coils in there to help keep them from rebleeding, and also nimotopine or nemotop. Can't even say it. Nimotopine is a drug that we'll give to help prevent the spasms. It's a calcium channel blocker, and they'll give that often to these clients. And you'll see that given up in the neurointensive care a fair amount. So the subarachnoid is also what we would deem as a neurological emergency. Certainly our goal is to preserve function. 20 to 30% rebleed in the first month if they're treated conservatively, like if they don't do surgery, they treat them, monitoring and what have you. So initial treatment is certainly going to always be to try to support vital functions. Early diagnosis is essential because obviously if they go into a coma and slip on into death, there's not a lot we can do about that. And you know about what the stroke signs and all that. So, but rebleeding is is the biggest risk. They may give them anticonvulsant therapy, which a lot of these patients who have any brain injuries are going to be on these drugs because of the likelihood of developing the seizure activity. Usually surgical repair will eliminate the risk of free bleeding.